Hello, I'm Andy Reynolds, Master of Ceremonies of NCQA's Health Innovation Summit 2024. NationsBenefits is a lead sponsor of the summit, and to learn about the company's work to improve healthcare, I'm speaking with NationsBenefits Senior Vice President for Measurement and Outcomes, Michael Blumental. Michael, welcome.
Andy, thanks for having me.
I'd like to discuss digital quality, and I'm curious about your work, your impact, and what you see coming with regard to digital quality. So I'll ask you three questions. What, so what, and now what? So let's start at the beginning, the what. Michael, what does NationsBenefits do to improve digital quality care?
I think we do a lot to improve digital quality care and quality outcomes overall. So our big idea at Nations, and I think this idea is consistent with what we heard at the Digital Quality Summit from many leaders and from NCQA, is we really want to focus on improving quality outcomes. And we've got a couple of ways we're trying to do that. First, we want to focus on patient-reported outcomes. We want to combine that with understanding health equity and health literacy. And we really want to specifically measure clinical costs, stars, HEDIS type of performance metrics. And in particular, we're very interested, because of the work we do, at better understanding the impact of things like value-added services in Medicaid, as well as the use of Medicare supplemental benefits. So some of these services would include things like food as medicine, hearing aids, groceries, nutritional advice, transportation, use of flex cards for members to be able to access things that influence their care and their outcomes, sort of in between the typical types of clinical encounters that you would have with a doctor, with a laboratory, with your pharmacist.
You mentioned your impact. Tell us a little bit more there. What is your so what? How do you know that you're having an impact?
Yeah, so great question. This is really a big area for CMS and Medicaid to investigate. CMS alone last year spent over $80 billion funding these types of benefits. And they want to understand what is the impact, both from total cost of care, but just overall outcomes and member satisfaction. How can this really help health plans improve overall performance trajectory? We're seeing star ratings starting to slide. We're even seeing members losing their health plan due to a lot of health plans having to exit the market because their performance isn't high enough. So this is really a time where CMS wants to understand, how are these rebate dollars getting spent when someone does get to the 4-star threshold? And we're even seeing this now in Medicaid. There's concepts called value-added services, where we're seeing things like transportation, doula-type services for moms giving birth, food as medicine. So it's really expanding, and we're expecting to see this move into employer healthcare as well. And so what we're doing about it at Nations is we're really collecting a lot of activity data from the 15 million members that we work with. So we work with over 120 Medicare plans, making up close to 300 Medicare H contracts. And so what we're trying to do with our customers, and we are doing, is we're collecting the data on all types of benefit use that is happening in between the member's traditional healthcare journey. So think about a member who might have a flex card to be able to purchase over-the-counter type of benefits, things like aspirin, Band-Aids, digital scales, produce that is covered, or healthy foods. We're able to track all of those interactions. We're even able to track what they're purchasing. So for example, if a member goes to the grocery store, we're able to track down to the actual individual product level whether they purchase something that has high sodium, low sodium, a lot of sugar, whether it's fruits, whether it's produce, whether it's frozen food. And so this really helps us when we start combining this type of over-the-counter purchase information on the types of goods a member is using. and we combine it with the claims data and the pharmacy data, it gives us a much more complete picture. So as an example, sometimes someone might be diabetic, but they're not diagnosed, or they haven't seen a doctor in the measurement year, but we might see them buying diabetic test strips, the continuous glucose monitors. Someone might be buying a blood pressure cuff. They could be buying like a lot of anti-inflammatory medicines, so maybe they have arthritis or something. And sometimes not all of this is in the claims data. So we have an opportunity to use our data that is near real time and feed it to the health plans, usually, 60 to 90 days ahead of when they would be getting their claims data analysis. So, when most people do HEDIS and STARS analysis, they're usually working on at least like a 90-day claims lag. So
Right.
we feel we can really get ahead of the curve this way.
Now, I want to double click on something that caught my attention. You mentioned groceries, food purchases several times. You're saying that you can tell if people you're helping or people covered by your services, you can tell how healthy their food is. You essentially know their grocery list or their purchases at the grocery store, right?
Yeah, that's exactly right. So we have partnerships with, oh gosh, probably 15,000 independent locations, hundreds of grocery chains. So we have a point of service. Basically, it's a way when you check out your groceries, it scans what it is, and it will say, oh, this is for Michael or Andy, and it's going to say, oh, Andy has this much on his benefit left to use, and this much of what's called a purse is allocated to healthy meals. This much is allocated to durable medical equipment. This much is just general over-the-counter stuff. So first, we can categorize it that way because we have to contractually, because the CMS dollars sometimes go into different persons. The second thing we do with the UPC code that's been around for, 10 years now or something, when that goes through our point of service scanner, or anytime we use our member uses the flex card that the health plan purchases on their behalf for these supplemental benefits, we'll know exactly what brand it is. We'll know if you're purchasing something from Nestle's, is it Cheerios, is it Raisin Bran? And we even have a database that tracks these macros as well. So actually, we recently acquired another company called Good Measures, and they're in a nutritional counseling business. And one of the things they do is they curate meals for diabetics, people with high blood pressure, high BMI, or cardiac conditions. And so what we're able to do is look at a member's food intake and have alerts when a certain percent of their grocery basket is high sodium or high sugar content. And that triggers an alert where we can message the member and try to, be a little bit, kind of promote health literacy around these foods. And, in many cases, we also offer meals to some of our customers. So when we see someone that looks like they might have an unhealthy diet, we first try to determine, is it because of dollars? Because obviously it's very expensive to have a healthy diet. And many health plans, especially in Medicare and Medicaid now, have a healthy food benefit, whether it's food as medicine or something called chronic meals for, it's called the SSBCI population for Medicare, or even post-discharge. A lot of health plans will pay for 14 days of meals because of the HEDIS measure. No one wants someone getting readmitted within 30 days of a discharge. Right. So we're able to put all that together.
That is remarkable. Out of curiosity, what is members' reaction when they get a message, they're a little high on the sugar purchases or a little higher on the sodium? What's the feedback?
Well, great question. And I think, everyone's, most people are adults, right, that we're working with. They don't want to be scolded, but what they want is, give me an alternative. Tell me something. Where can I get something? How am I going to get it? So number one, we can curate meals using some of our artificial intelligence and our backend database that says, you seem to like this type of food. How about you take the same type of food, but we're going to tweak a little bit of the ingredients and the macros, and this will get you closer to your daily allowance. And we also have a list of the medications they're taking and any other self-reported conditions or conditions that the health plan reports to us that their members have. So it really gives us a better idea of what's optimal. And when you mix that with, like, what medication are you taking, that really helps us figure out how to better engage. The sort of the second aspect of that is we actually have meals. We ship over, I think it's about 55 million meals we shipped last year to about 75 health plans and a couple 100,000 members. So a member gets discharged, they might get an original, 14 days of meals, so 42 meals, and sometimes they'll get authorized for more meals. So, you think about, I think we got 15 million members from 40% of the Medicare market. That's a lot of potential when you think about all the inpatient visits. So we're taking that data and really trying to look at things like readmissions and how do we engage the member immediately after discharge. Hey, we're going to send you these meals. We'll call them a few days later. How are these meals tasting? How's your discharge going? Have you set up your appointment with your PCP yet? Is there, do you have someone in the home taking care of you? Do you have a ride to the office? These are the types of things we're really trying to partner with our health plans on, because we know there's a lot of unnecessary costs in the system. We also know the STARS measures, 3-point weighted measure, a number of HEDIS measures on follow-up after mental illness, or just no 30-day readmission, all that kind of medication reconciliation. So these are all really good opportunities to nudge the member with something that they need, healthy food that's hard to afford and takes a lot of time to prepare. That's kind of what we're all about. So trying to really meet the member more holistically and let the health plan do what they're good at and we do what we're good at, and sort of that combined 1-2 punch, I think is really more helpful in engaging the member.
Certainly, that is impressive.
And let me tell you about where the digital quality piece fits in, because I think you were asking about that.
Yeah.
So we're a big proponent of FHIR, and we're thrilled that NCQA is really leading the charge on ECDS measures and getting data directly from the providers in more real time. So what we're also trying to do here is bi-directional data sharing, both with pharmacies and with provider systems. So when we're able to capture a lot of this that we're talking about is health equity and social risk factor data. And it obviously plays into a lot of measures, especially with the aging population and Medicaid. So we're doing more bi-directional sharing. We're a big proponent of FHIR, and we're looking for ways to sort of package this social risk factor data that is sort of more real-time with the FHIR data that is more real-time, to be able to curate a more complete picture of the member's health journey in between the health plan learning what they typically learn, which again is every time there's a data refresh, and it's usually 60 days in arrear, if not 90.
Right. We've heard about your what, very impressive. So what, your impact. Let's look ahead to the now what. What do you recommend that people who care about healthcare quality, what should they know or do now with regard to digital quality?
Great question. Yeah. So one of the first things I think I just talked about is we really need vendors and health plans to embrace the idea of sharing information. NCQA did a fantastic session, I think, with Peggy O'Kane and the former CEO of Kaiser, did a wonderful session on generative AI, narrow AI, and really why plans really need to embrace this, because there's just so much waste in the system, and we're seeing just continued explosion of chronic conditions. So the ability to share all this data that is coming from connected devices, digital devices, member self-reported, FHIR, that's really one thing that we want to advocate for, for all of the vendors. The second thing, is if we talked a little bit about FHIR. So, number one, it would be great if ECDS could be a little bit more flexible. I know you're hearing from some health plans, like they're just really getting started in their digital health journey. Providers are getting their FHIR servers up. Health plans are investing in really getting ready for digital quality. I think just to really ensure the explosion of that adoption within health plans, there needs to be a little bit more flexibility on those measures, best practices from NCQA, benchmarks from NCQA Quality Compass, but really to just get people to understand, hey, this really works if we all share information.
That's well put. I think that's a great place to leave things. Michael, thank you very much to you and your colleagues at NationsBenefits for being a lead sponsor of the Health Innovation Summit. And thanks a lot for speaking with me today.
Yeah, it was our pleasure. Thanks, Andy.